But I think we have to be very careful that the information today is really preliminary, and it really is. It's based on studies of studies as opposed to a very good trial that could very well answer the question if it's allowed to finish.
So basically we're just asking physicians how the recent publications on rosiglitazone have affected their clinical practice. How has it affected your clinical practice?
Well, I've decided not to use Avandia in my practice.
Okay, well I think use of the TZDs is quite different in Europe to in the United States, so we don't use them as very much at all really. So for my own personal practice it's made very little difference because they're not a drug that I would use regularly anyway.
We've had a lot of patients call concerned and wanting to possibly switch or just wanting more information. The endocrinologist, I'm a physician assistant, and the endocrinologist that I work for has basically said he's not so sure he believes the study. He wants more information. So we've been reassuring, but we've also, if the patient's very concerned, we've been switching to Actos.
I think it certainly has an impact on my research because I think that with rosiglitazone, by the trials on humans, it certainly increases adipocyte differentiation and improves insulin action. So I think if there are more researchers on cell biology that illustrate the mechanisms on rosiglitazone action, that would tremendously improve our knowledge on potential cures on diabetes and diabetes research.
I'm a researcher in a company, pharmaceutical company, yes.
Okay, so how has it affected you and your company?
It's too early to say.
How the recent publications on rosiglitazone have affected your practice?
One of the most disastrous things I've ever had.
What are you anticipating to hear this evening that may affect your clinical practice or help you make decisions?
Well, this has already been published in the New England Journal, so I'm not sure that I'm going to be hearing a lot of new factual information. This will be the reaction to the factual information. I'm also not sure I'm going to be able to be here to hear it. And I'm amazed at how many people are lining up more than an hour before the start of the talk.
I think it's very interesting, the publications that have come out in the literature in the last few weeks. I think it just underlines the importance of big outcome studies to really look into the safety and efficacy of drugs that come onto the market for diabetes.
So
I think part of the main target is PPAR, and the expression of PPAR is certainly not restricted in one tissue. It's mainly in a lot of tissues, and besides impact on diabetes, also has a great impact on cancer. So I think besides whole animal physiology studies, there should be more research on at the cellular level, like not only the adipose tissue, those insulin response tissues, but also the endothelial tissues, which has PPAR and has a great impact on physiology.
Really, it's a serious problem. I think it's the most unethical thing that the New England Journal has ever done.
Had one mother call me after all of this was in the press, and she said, "Dr. Deeb, I'm afraid for her to take it." And we sat down and talked about it. And she may actually retry metformin. But the truth is, she needs to be treated. And so it's really important as we unroll this, that patients really look at what they're doing and why they're doing what they're doing in the context with their doctor. To just stone cold stop a medicine that you actually may need can be wrong. If you're maybe taking it for marginal reasons, and you might do something different, or if there may be some perhaps increased risk to taking it, then fine.
Well, TZDs are obviously powerful drugs in controlling diabetes, so I don't think we should diminish their effectiveness in our armamentarium for control of glucose. What will happen perhaps, I think, is as patients age, as patients accumulate more cardiovascular risk, maybe the TZDs aren't going to be optimal in that setting. But certainly in my setting of the young patient developing type 2 diabetes who has tremendous insulin resistance and who is at low risk for at least an imminent cardiac event, I think there is a real role for these agents.
Are you going to the session this evening?
I'm going to the session because I'm curious.
Okay.
To listen to the effect of the cardiovascular findings. Yes.
Right. And what are you expecting to hear this evening that may help you make clinical decisions or treat patients?
The information, basically the expert opinions on basic, just kind of, I want to hear it from the experts.
What are you expecting to hear this evening that may be of interest?
I think it'll be interesting to see some of the world leaders in this field discuss these results. I know that there's been a lot of discussion about the methods that we used to generate the results for the article in the New England Journal. I think there was an issue that the researchers who wrote the article didn't have access to all the information that they needed from the drug companies. In particular, they weren't allowed the patient-level data, and I guess it highlights the fact that that kind of information probably should be in the public domain to fully assess the safety of drugs.
This has now become a debate on epidemiological data analyzing or analyzing data from meta-analyses, which most people don't understand the difference, and particularly how it affects clinical judgment. And therefore, the clinical aspect has been subjugated by a discussion of meta-analysis, and that makes it very difficult for us in clinical care delivery. People don't understand that it's very hard for people to control diabetes, and every instrument that we have at our availability is important. And it's just the same as with the Vioxx. The Vioxx was withdrawn, and there was really no justification for its withdrawal. People can make a decision on risk ratios and risk, but this is a disaster because when it's presented in this way, people haven't got the capability of making that decision themselves, and they make it on media basis, and it was a media explosion. So I'm not happy with it at all, obviously.
First of all, I was very pleased. The audience was very responsive. They applauded. They understood why it was important to get this information out there. And every time I talked about the alternative, which was not to publish, they understood. And while it made life more difficult for the diabetes community, they understood that, providers and patients have a right to this information.
I've heard diabetes specialists say that even if they believe strongly in the benefits of the TZDs and wish to continue their patients on these drugs, that they're getting pressure from lawyers, from the legal community, to stop using the drug, kind of under the threat of a suit or perhaps a class action of some kind. Do you feel that...
That's the most regrettable aspect of this, is that there are always people who will want to take advantage of the situation. Unfortunately, I can't consider those issues. In terms of what you publish, you can't worry about how the legal community is going to interpret the findings. The best thing I can do is to put the information out there and very carefully enumerate the strengths and the weaknesses of the analysis, which I really tried very hard to do. And hopefully that allows people enough wiggle room to make their own decisions. And I really felt strongly, I actually disagreed with several people like Philip Holm. I do think it comes down to what an individual decision, what an individual physician decides to do for an individual patient. And in that setting, you want to have all the information that's available to you to make that decision, and then you look into your own heart and you decide what you think is right for your patient.
Speaking as a cardiologist now, obviously not a diabetes expert, but if a patient were to come in to your office on this drug, what would you say or do?
Well, again, I'm not in that position, and again, I'm not a diabetologist, and so what I would do is have a dialogue. I would certainly want to make sure the patient was informed, and I would also want to make sure that their provider was informed. But ultimately, it really does come down, I don't treat diabetes. Diabetes doctors, sometimes internists and family practitioners do, and I wanted to make sure they have the information that they need, and that's exactly what we did. I believe that when we expose a patient to pharmaceutical agents for the purpose of an experiment, that the results of that experiment belong in the public domain. And so what I want, we were very fortunate here, and that is because of Elliot Spitzer's lawsuit, we had access to all of the Avandia clinical trials. That's really very rarely true in medicine. We need transparency. We need our system to be changed to make it mandatory to publicly release such information. Only through complete transparency can we make the best decisions for our patients.
Thank you, Dr. Nissen.
Thank you.